I sent him, he asked me what my title was going to be, and I said it would be Bad to the Prone. And in this post or COVID world, it's tough sometimes through text messages and not being face-to-face to realize that that was a joke. And then he sent it to Dr. Welton, who sent it out to everyone. And so now it's called Bad to the Prone. And hopefully that is the last pun that I will have during this talk, but let's kind of move on here. So the objectives of this talk, I think, would be to understand the physiology, what's occurring in the thorax when someone is supine versus when someone is prone. And then I think another topic would be try to identify which of these COVID patients would benefit from conscious proning, if there is going to be benefit. And then also, how are we going to teach our patients how to prone? All right. So, when I started taking care of these patients, it was kind of hard for me to get an idea of what I can do to help them. And so, I thought, can I give them some sort of medication to help? I mean, I can give them Tylenol, but is there a medication to really help their virus? And the answer is, right now, at least, is no, especially with the azithromycin hydroxychloroquine not being working. And then maybe some studies will show other medications. But for now, it's a no. Well, can I check labs and see if I can prognosticate their condition? And the answer is yes, I can do that, but I still kind of care for them based on their clinical symptoms, right? If they're on 1 liter of oxygen, it doesn't matter that their ferritin is 10,000 if they're just, they look terrible. But I'm not going to give them tocilizumab or anything like that, or send them to the unit just based on a lab. Well, can I do what good hospitalists do and comfort them by a kind and caring bedside manner and exam? And it's pretty tough to do that through all the PPE. It really is. There's the HEPA filter is going, and so it certainly changed the way the patient-doctor relationship is right now in those rooms. And so that's tough. So I thought, what can be done? And like I had said, there had been all this kind of social media and anecdotal evidence that maybe proning would be helpful. And so I kind of want to talk a little bit about where this came from, why we think that proning might be helpful. So there's a large trial, and people in the ICUs have been doing proning for a while, but this large trial, which called the PROSEVA trial, or the Prone Positioning and Severe Acute Respiratory Distress Syndrome, came out in 2013, I think in New England Journal of Medicine. And it was a multi-centered, prospective, randomized controlled trial, which saw a couple of different centers in France and Spain. And it looked at 466 patients with severe ARDS. And it randomized them into 2 groups. So one, the experimental group was 16 hours of prone positioning. And then it looked at others, just kind of the standard of care, which is patients being left supine. And they wanted to know all-cause death, what does it look like at 28 days? And the results are pretty dramatic, guys. If you look at this, you can see that the Kaplan curve, you can see it actually, there's a big divergence between these lines, the supine group and the prone group. And it seems like the p-value is significant. And this, we go forward here, the 28 days mortality was 16 in the prone group, and it was 32.8 in the supine group. So that is significant. And like this chart shows, it persisted all the way out till they stopped following them. So this is pretty remarkable as far as the benefit you get from doing something to a patient. And so the question was, well, why does this help? Why? What physiology? What would be the reasoning for this to help? And so when we think about it, it's, what is actually happening? And so when the patient is supine, there's let's break the lung up in 2 parts. So there's the ventral lung, which is kind of closer to the sternum, and then there's the dorsal lung, which is in the posterior, closer to the spine. And when you're just laying prone, the heart, the ventral lung, the abdomen to some degree is putting a lot of pressure on the dorsal lung. And this actually leads to more atelectasis in the dorsal component of the lung, less inflated alveoli. And you can actually notice there are some studies out there that actually look at the density of the lung tissue, the parenchyma, from the sternum to the spine, and it actually increases. So you can see that that there's less air in the dorsal area. And so when you flip them over, perfusion stays pretty homogeneous. There may be a little bit of change just by gravity, but for the most part, it's pretty homogeneous. But what does happen is that you actually cause more recruitment in the dorsal aspect of the lung. So in the posterior aspect, or I guess the dorsal aspect, which is the larger part of the lung. And that exceeds the amount of de-recruitment in the ventral lung. So basically, you might lose some alveoli in the ventral lung, but you get more in the dorsal lung. And so this actually matches VQ much better, which leads to better oxygenation of the blood. And so I guess this is a study that I started to look at as far as, is this actually true? Is this actually the physiology that's going on? And so it's a 2006 study that came out of Greece, and it looked at 21 patients who were intubated for either acute lung injury or ARDS, and they were being, and so what happens is they took those patients and they were in supine position. They all got similar ventilator settings. They did some recruitment maneuvers, which is like increasing the transpulmonary pressures during titling and finding the optimal PEEP. And then they sent them down for a scan. They would do a CT scan, and then they would bring them back. They would put them in prone position, and they would wait half an hour, and then they'd send them down for a second scan. And they basically wanted to see what the lung looked like on the CT scan between the two scans. And so here's someone that is supine, and you can see that this guy does have some pneumonia, or at least atelectasis, right here around the spine. You can see his heart is right here, closer to the sternum. And then over here, you can see that the heart is now on the bottom of the screen. The sternum is on the bottom because he's now supine. And this is the same slice, or what is as close as I could find as the same slice of the CT. And you can see that the lung is actually kind of opening up here. They actually went and looked, and they studied based on Hounsfield units. They came up with some algorithm, looked at both the right and the left lung. They found that these lung is kind of aerated much better after they're prone. So this is the well aerated lung is this gray part. You see, once they went to prone, it improved. In the over aerated or over inflated, so not as effective alveoli, actually decreased. And so they also looked at these patients as far as their PaO2, and it actually improved when they went supine, but we'll talk a little bit about those numbers later. But I think what this shows is that the physiology is there, that your lung does expand. And now this is all in ventilated patients, and this is the standard of care in the ICU for patients with ARDS, is to do the prone protocol. But will this help our patients? Because the physiology is still there. Now the lungs aren't as sick, and so that might change things, but the anatomy is the same. So does it apply to our conscious patients on the floor? And so I kind of looked at some more studies. So this is where people got into actually why they're doing this with COVID. And so when the outbreak in Wuhan occurred in late 2019, the death rate was significantly higher than when it spread into the next province, the Jiangsu province. And they had a very brief article in the Annals of Intensive Care where they said that the reason why they had improvement in their mortality was because they did this. They were more aggressive with non-invasive and high flow nasal cannulae. They did a restrictive fluid resuscitation so that the patients who did develop ARDS, they weren't overloaded. And then they put the patients in awake proning position. And what they said is basically, this is all they said. They said, this is in the whole article, this is what they said about proning, is that we attempted to awake prone positioning, and they called it novel coronavirus, but COVID patients, which showed significant effects on improvement of oxygenation and pulmonary heterogeneity. And that was it. And that's where I think people have now started doing it on the floors in New York and other places that are heavily hit. But again, they don't go on to talk about what exactly they did as far as how long they were in prone position, who was chosen, how it lowered mortality. So it was not like a convincing argument that we should be proning these patients. But, you know, in the lack of a lot of good data, I think people have decided to do that. So I wanted to look at, we know that proning in someone who is ventilated does seem to help, but I wanted to also see, is there any studies out there that would look at patients who are not intubated, whether they're on non-invasive ventilation or face masks or nasal cannulae. So there was actually another, not a great study, admittedly, but it was this study from Italy in 2015. And it was a retrospective observational study that looked at 15 non-intubated patients with hypoxic respiratory failure. So they met criteria for ARDS if you look at their PaO2 and FiO2. And those 15 patients had 43 prone positioning procedures where they basically flipped the patient prone and it lasted for at least 2 hours, or on average 2 hours. And then they measured the PiFO2 at 3 different times during that procedure. So 1 to 2 hours before they flipped them prone, then during prone, and then 6 to 8 post-prone, or when they were back to being supine. And they were on either oxygen mask, high flow nasal cannulae, helmet, CPAP, which is that bubble that you see the Italian people have sometimes, and then also mask non-invasive ventilation. And unfortunately, because there wasn't really a strict study here, because it's a retrospective observational, they were able to flip back and forth between all of these devices. And so what they found was actually pretty striking. They found that there was a statistical significance in the PaO2, even when you controlled for changing devices. So if you didn't change the device, or you didn't change the PEEP or FiO2, you saw this dramatic increase from where they were. This is where they are prone. They're pre-prone. So before they go and get prone. And then after 6 or 8 hours, they're back to their normal self. Okay. And so this shows, at least to me, or at least makes you think that these patients may benefit from being prone as far as oxygenation. This didn't look at survival or anything like that. And you can see these numbers are pretty striking, right? So these are pretty sick people with their PaO2 of 88, and it jumps up to 131. And this is without any changes in their FiO2 or the device. And then it's back to 91. So more recently, there was a prospective observational study of cohort in 2 centers in China in the beginning. This was published in January of 2020. And this didn't look at COVID patients either. But what they found was that they took 20 patients that were in either moderate or severe ARDS, 10 of them moderate, 10 of severe ARDS. And they wanted to know how many of these patients would be intubated, and they compared it to historical references as far as how many people end up intubated with moderate or severe ARDS, which is around 75%, 60 to 75%. And so they either placed them into this, well, I'll show you the way that they broke down their study or their procedure. And they averaged 1 to 4 hours of prone per day. So again, this is much less prone than what the PROCEVA study showed, which had sick people who were on 16 hours of prone a day on a ventilator. And so these patients who were found to have moderate or severe ARDS were brought to the ICU and put on non-invasive for 30 minutes. So kind of recruit as much lung as they could in a supine situation. Then if they were stable, as far as an SpO2 of greater than 90, they would basically put them into on a high flow nasal cannulae. If not, they continued to be on non-invasive positive pressure. And then they also put them in prone positioning. They would then take the people who were stable and then put them in prone. And if they benefited, they continue it. And if they didn't benefit, they would switch to non-invasive and then eventually put them in prone positioning. And then if that didn't work, they would intubate them or continue them on. And then they checked basically how many of them ended intubated and what their PaO2, FiO2 was at each, compared to each step up. And so 11 of 20 people avoided intubation, which was a trend. So that's 45%. And like I said, historically, people with moderate to severe ARDS were 61 to 77% get intubated. And then they also looked at their oxygenation. And so you can see that someone who went from this high flow nasal cannuli, their FiO2, again, these are sick people, 95 PaO2 to FiO2 ratio. And then it improved to 130, which was significant. These are the successful patients. The failure patients did not improve, and failure means they were intubated. And then if they failed that and then eventually became successful, they went from high flow nasal cannuli to positive pressure, and using non-invasive was actually another step up. And that was also significant as far as keeping them out of being intubated. Okay. If they got to non-invasive ventilation, probably, and they did not seem to benefit, even if they were successful, by putting them in prone positioning. And I suspect this is because they've already been prone earlier in the course for most of them. And so if it didn't work here, it's not going to work again. You're not going to get more prone or dorsal recruitment if they've already been prone. And the failures, they kind of just failed. You know, the ones that weren't going to benefit, they just didn't benefit, and they went eventually to be intubated. So again, none of that's great data saying the benefit of putting patients prone, but there needs to be a randomized controlled trial, and people are doing this. So this is the exact handout that people in Elmhurst, the doctors in Elmhurst Hospital, were giving to all of their COVID patients, where they basically call this a pig roast to some degree, which I probably wouldn't say in front of the patients, but they would be lying prone for 30 to 2 minutes, and there's the Spanish here, and then they would lay on your right side, and then they would sit up, and then they'd lay on their left side, and they just continued to do that. Now, no data was really collected, because I think it's probably difficult to collect data in chaos that New York was, but they certainly did it. And in fact, the Intensive Care Society, I guess, was at least anecdotally impressed by this data, that they decided that they would also put out the same algorithm recommendation for patients. If you can see, this is their algorithm that they just put into print a couple of months ago. And so the first part is, are they requiring oxygen, or they're requiring any kind of support? So I think that's like incentive spirometry, that's albuterol, HMIs, anything to keep their stats elevated. And then they said, they have to be suspected or confirmed of COVID. And if they are, and they're able to coordinate with being prone, right? So they can't be altered, or they can't be, overly obese. If they are, then you would continue to think about putting them in prone. If they're in respiratory distress, meaning that their respiratory rate is greater than 35, or the PaCO2, I think this should be 65, or they're working accessories, then they would be contraindicated to do that, or they're hemodynamically unstable or altered, or if they were pregnant was a relative contraindication, or morbidly obese. But if they didn't have any of these absolute contraindications, then they're recommending that you could try to put them in prone positioning. And so this is what they would say, is basically put them in, monitor oxygen saturation for 15 minutes to see if it improves. And you can give them that handout and see if they'll get better. If they don't, then you can stop. But it seems like they're saying it's worth trying. And right now, as a hospitalist and seeing these COVID patients, there's not a lot I can do to intervene. I think this is worth trying. And in fact, I think what we really need to do is find out more information. And so Dr. Fisher and I are actually trying to be involved in this multi-center randomized controlled trial, looking at proning in these patients. And so we've submitted an IRB, and the way it's going to work is we enroll patients, and I'll show you the inclusion criteria, which is very similar to what the Intensive Care Society is recommending. But we enroll them, we ask for their phone number if they're willing to give it to us, and someone at Boston University has a program that sends out a message to the patients if they're either in the usual care arm, which is basically just lay on your belly or lay on your back, versus the interventional, where it basically tells you when to rotate. So rotate onto your back, rotate onto your side. And it also asks them to put in how long they've been laying on their side, laying on their back. And they're recommending 30 minutes to 2 hours for each. And so hopefully when our IRB is approved at Georgetown, we'll be looking for patients that have COVID-19, either confirmed or PUIs. They They have to be greater than 18. They have to speak English or Spanish because that's the messages they're going to get through their cell phone. And it needs to be early on their course, so within the last 24 hours. If the patients have fractures in their chest, obviously it's not a great idea for them to be rotating. If they need supplemental oxygen greater than 6 liters of oxygen, I don't think we want to look at those patients. If they're hemodynamically stable or pregnant or have comfort measures, those are patients that probably won't qualify for this study. But I think when we do get the IRB, I will talk with the admitting team and maybe some of the nocturnists to see if we can start enrolling some of these patients to try to figure out if doing proning on the floor is helpful.